who is the director of the brain tumor program at Brown University, and also a professor of neurosurgery there. And we are going to discuss a very novel approach for consolidation treatment with laser interstitial thermal therapy combined with stereotactic radiosurgery for newly diagnosed brain metastases. So without further ado, we'll let Dr. Chen take over and present his work.
Thank you so much for having me and giving me the opportunity to share this work. Can everyone see the slide okay?
That looks
Okay,
great.
Looks great.
thank you so much. So to start off, these are my disclosures. I do use the Medtronic device to perform laser ablation. And that's part of the disclosure. So here's the roadmap for today's presentation. I would like to review with you the efficacy of radiosurgery in newly diagnosed brain metastasis and where we might fall short as opportunities for future developments in technology. And then I will provide some rationales for the treatment that I'm discussing, which is laser ablation, followed by consolidation, stereotactic radiosurgery. And I want to present some data in terms of brain metastases that have been treated using this strategy for both tumors that recurred after stereotactic radiosurgery, as well as newly diagnosed brain metastases. So I do believe that brain metastasis will be an emerging health epidemic going forward. And for this very simple reason that cancer is effectively a disease of the elderly. And you can see from this slide that the risk for cancer development increases exponentially after the age of 40. And our population is aging. If you look at between 2020 and 2040, or rather between 2007 and 2040, the number of individuals age 65 or older will have doubled. And that would mean that the risk or the prevalence of cancer will double within that time span. From studies done by Posner and Chernick, we know that a significant proportion of patients who are diagnosed with cancer will face the challenge of brain metastasis. In their study, it's estimated 25 or roughly a quarter of patients with cancer will develop brain metastasis. This number will likely increase in the context of systemic therapies are effective but do not penetrate the blood-brain barrier. So currently, stereotactic radiosurgery is a major modality for the treatment of brain metastasis that does not require surgery. And you can see that the data for the efficacy of stereotactic radiosurgery has really reached maturation. We now have 5 randomized control studies demonstrating the sort of quantitating the local control that can be achieved with with radiosurgery. And impressively and consistently, in all 5 randomized control studies, the local control rate for all brain metastases across all sizes and all histology is about 70%. And what that means is at 1 year, there's an approximate 30% recurrence for brain metastases that were not resected, just radiated with radiosurgery. Now, this 30% is an average. We know from a large body of literature that the larger the metastasis, the more likely it is to recur. There's a beautiful paper that summarized essentially decades of work by Dr. Swaya's group, published in Nature Communications just this year, looking at the risk of brain metastases that were not resected and treated purely with radiosurgery. And what they did in this particular figure is they stratified by size. So if you have a lesion that's less than a centimeter, the chance of control for radiosurgery is enormously high. It's the 80 to 90% that we often quote to our patients. However, as the tumor gets larger, 1.5 to 2, 2.5, 3 centimeter, the likelihood of local control decreases significantly. Here I put the red line across 70%, which is the average from the 5 randomized control studies that is shown on the left panel. So indeed, this 30% local failure is an average across all sizes, and the larger the tumor size, the more likely you have recurrence at 1 year. Now, is this unique to tumors that are not resected? No. If you were to look at the beautiful paper from MD Anderson, where they looked at the efficacy of resection cavity radiosurgery after tumor removal, you see the same thing. If you have a resection cavity that is less than 2.5 centimeters, you get a very reasonable control at 12 months. But that number goes down to almost approximately 40% if the resection cavity is more than 3 centimeters. So the larger the lesion, the less likely we could achieve local control with stereotactic radiosurgery. And we know this. This is fundamentally consistent with the fact that dose matters. The larger the cavity, the larger the tumor, the less dose we could deliver to the area of concern. So there are subsets of patients who are treated with stereotactic radiosurgery that really needs for a strategy for augmenting local control. And one of these subsets are the patients with larger tumors, however you define that larger to be. There is it's another subset of patients, and that's also reflected in this graph. Notice that most of the recurrence happens after approximately 6 months. So the reality is, the longer the patients live, the more likely the radiosurgery treated tumor will recur. Here's one of my own patients. This is a patient with a breast metastasis that I treated with radiosurgery, and you can see that essentially melted away after radiosurgery. However, this is also a long-term survivor. So after about 18 months, you can see this fuzzy area growing back, and it got bigger and bigger. Ultimately, we resected this, and this indeed was recurrence. So the longer the patients live, the more likely that stereotactic radiosurgery will fail. And in fact, in the early days when we had very high control rate of radiosurgery, a part of that is due to the fact that many patients died before the tumor recurred. Keeping in mind, in this context, it's important to keep in mind that patients with brain metastasis are living longer and longer and longer. Here's a study from BMC Cancer demonstrating that patients with melanoma that were treated with PD-1 antibody with brain metastasis are surviving with a median survival of 3 years, whereas those patients who were not treated with the PD-1 immunotherapy do not survive or achieve the same survival. So in the context of longer survival, we are going to need tools that will allow us to augment the therapeutic efficacy of stereotactic radiosurgery in terms of achieving local control. And finally, there is a subset of patients whose tumors are just intrinsically resistant to radiation. Again, we need to develop tools to help these patients. This is a study that I performed many years ago with one of my good friends, Wen Kao, where we profiled melanoma that's metastasized to the brain relative to those who are in their sort of endogenous dermal compartment. And what you can see is on the x-axis or on the columns here, these are expressions of DNA repair genes. What is very evident is that when the tumor becomes metastatic to the brain, these DNA repair genes are highly overexpressed, as indicated by the red color. Green indicates low expression, and these tumors are intrinsically very resistant to radiation. And in fact, for melanoma patients, and this series was published, we published this series, but this is before immunotherapy. So to what extent this applies today, it's unclear, but you could see that the 12-month local control rate for melanoma back prior to immunotherapy can be as low as 60%. So the bottom line for these slides is to say to you that there are subsets of patients who really needs a therapeutic strategy that will allow us to augment the efficacy of radiosurgery in terms of achieving local control. So Next, I'd like to talk about one strategy that can help us as surgeons to achieve that goal. And this is a strategy that I termed LITT, followed by consolidation stereotactic radiosurgery. So, as a brief note, laser thermal ablation is something that's familiar to this audience. It is basically a procedure whereby we insert a laser probe into a region infested by tumor, activate the laser probe to cause heat, causing thermal coagulation and destruction of the tumor. This is a procedure that's catching on rapidly. This is a paper that we published last year demonstrating that between 2018 and 2013 and 2018, the utilization of this procedure has increased by 400%. But yet it's still a very small fraction of the total number of craniotomy performed. More and more, we have data as to the safety of this procedure. This is another paper that we published demonstrating using the National Readmission Database that the risk of readmission within 30 days or 90 days are comparable between LITT and stereotactic needle biopsy. In fact, we have also looked at the complications, and in fact, the complication rate is comparable between laser ablation and needle biopsy. So this is a very safe procedure whereby we could significantly cytoreduce tumor burden for our patients. Now, the efficacy of laser ablation as a standalone agent in the treatment of brain metastasis, unfortunately, has been disappointing. The first paper that reported investigation of LITT in brain metastasis as a treatment came from Veronica Chen, who conducted a prospective study examining patients who are afflicted either with metastatic disease, brain tumor or radiation necrosis. And the outcome of the paper is that LITT is enormously effective for the treatment of radiation necrosis. However, approximately half of the patients who had brain metastasis recurred after LITT treatment. And this data has been recapitulated subsequently by at least 3 separate investigators, where the recurrence rate after LITT alone for brain metastasis is on the order of 30 to 40%. So LITT alone is not a great option. Now, why might that be? Well, fundamentally, radiosurgery is an extraordinary tool because we can conformally deliver the radiation to precisely the region that we're concerned about. The precision of radiosurgery is exquisite and unmatched. Now, when we're doing LITT, however, as you can see from this thermogram, where the temperature propagation is seen as the pixel turns yellow and orange, the propagation of the heat cannot be controlled in the same way. It's not as precise as radiation delivery. Heat delivery is imprecise. It's a function of the tissue density. It's a function of how close you are to the ventricles. It's a function of how close you are to major blood vessels. So it stands to reason if there's a region of the tumor that's not ablated, it creates an opportunity for that small segment of the tumor to grow and recur. So that is the challenge of LITT. Now, if you have a tumor in a region where you could safely extend your heat zone beyond the contour of the tumor, then I think you could achieve a reasonable control. However, there are many tumors located in deep-seated regions where you don't have the luxury of heating beyond the tumor because that increases the risk for surgical morbidity. And so that is why I believe that LITT as a standalone for treatment of brain metastasis is not optimal. However, realizing that LITT is also a great treatment for radiation necrosis, and it also can cytoreduce, there's an opportunity to combine the 2 modalities. And these are essentially 3 reasons why I initially developed the LITT followed by consolidated SRS paradigm. We do know that within the area where we induce hypothermia, there will be a kill zone, and we will be able to cytoreduce with LITT. And we also know radiation kills the tumor in a fractional manner, meaning that it doesn't kill every bit of the tumor, it kills a fraction of the tumor. So the fewer tumors you start with, the more likely the radiosurgery or radiation will succeed. That is a fundamental principle in radiation oncology. So cytoreduction will certainly augment the efficacy of radiation. There is also, apologize, there's also a documented synergy between hyperthermia and the cytotoxic or tumoricidal effect of radiation. And interestingly, the synergy persists beyond the immediate days after hyperthermia. In other words, hyperthermia trigger biological changes that persist for days, so that you could perform a LITT followed by consolidation SRS and still augment the therapeutic efficacy of that stereotactic radiosurgery. And third, and equally importantly, Veronica, in her landmark study, has demonstrated that LITT is a great treatment for radiation necrosis. One of the major problems with the radiation delivery is that we cause radiation necrosis. So by treating with LITT, combining LITT with SRS, we potentially mitigate the eventual effect of radiation necrosis, especially for larger tumors. So those are the reasons why I developed this paradigm. So about in 2013, 2012, 2013, we wrote an IRB protocol and explored the following paradigm. As this is new, all the studies done in 2012 or around that time was under IRB approval. So the basic process is, as with all new modalities, we first treated it patients with brain metastasis that recurred after radiosurgery. So BMRS, brain metastasis recurred after radiosurgery. Each of these patients are reviewed in a multidisciplinary conference so that we have input from oncologists, radiation oncologists, and myself. And there must be a consensus before we enroll the patient in this treatment. Essentially, what we do is we would do a biopsy to confirm that this is metastatic, because this is something that recurred after radiosurgery. It's possible these are radiation necrosis. And at that time, remove the biopsy needle, insert the laser probe, thermocoagulate, and then within 30 days, we treat the patient with 5 gray by 5. We had a lot of discussions as to whether we could treat this with a single fraction or a 3-day fraction or 5-day fraction. We ultimately picked 5 gray by 5 because this is the gentlest regimen while achieving tumoricidal effect. And this really was modeled after the Stanford papers, where they radiated pituitaries that are essentially in contact with the optic nerve with the 5 by 5, showing that there is reasonable safety for this regimen. We were concerned that the LITT may augment the effect of radiosurgery, causing harm. So we used the gentlest hypofractionated radiosurgery regimen available at the time. So this is the very first patient that I treated with this regimen. And this paper was published in 2016. We followed this patient for approximately a year and a half, 2 years after treatment. This is a patient with colon cancer that recurred after radiosurgery. You could see there's some surrounding edema. We performed LITT, which caused expansion of the contrast-enhancing lesion as seen in panel B. And this is expected of a lot of patients who underwent LITT. This is the reason why we don't treat a significant size lesion with LITT, because the mass effect that's produced from this swelling can cause significant mass effect and neurological injury. In any case, the patient then underwent radiosurgery. This is when I was in San Diego. So we used a Linac-based radiosurgery and treated this entire volume. And then we follow this patient. And so this patient, this is at 3 months, 6 months, and then a year. And this patient, the tumor remained in control despite systemic recurrence after approximately 2 years. The patient ultimately died from systemic disease progression. But at the time of at the time of her death, the MRI that was done prior to her dying, you still see excellent local control. So this is and most importantly, what you can see here is that flare abnormality went away. Remember, LITT is also a treatment for radiation necrosis, right? So then in this paper, we reported four such patients, all with just outstanding outcomes where the tumor, the local control extended beyond 2 years. And that led us to continue to investigate this. So when I took joined staff in the University of Minnesota, we continue to collect patients who brain metastasis failed after radiosurgery, and we treated them with the same process, multidisciplinary review. We follow them carefully through IRB, but over the span of 7 years that I was there, we only collected a very limited number of patients. But around this time, through this through this time, I was also advocating for this treatment paradigm, and I was able to convince many of my colleagues to also adopt this paradigm, including those folks at Duke and the Cleveland Clinic and at Yale. And so we pooled our results together in this paper that we published now in 2022. So this is 6 years later. And again, what we saw was a very impressive local control. None of the patients who were treated in this way required steroid use referable to the treated lesion. And the local control extends beyond almost 3 years. So that was very reassuring. And then we collaborated with Peter Fecci, where we contributed our patients to a series I was collecting, where he compared patients with brain metastases that showed increasing enhancement after radiosurgery that were biopsied. These are patients who are subsequently treated either with SRS alone, with LITT alone, or with LITT plus SRS. Here, plotted on the right side is the local control. And what you can see is of the patients who are treated with LITT and SRS, the recurrence is fairly rapid. Whereas with LITT plus SRS, there are durable control that is seen in those treated patients. Now, this is a retrospective series. Peter has subsequently proposed and it's in the process of carrying out a prospective study to validate this finding. So more to come as he completes his study. Now, with that in mind, as I see this data set matured in the brain metastasis that recurred after radiosurgery, my attention turned toward those patients who are at high risk for recurring after radiosurgery. Remember, the larger the lesion, the more likely they're going to recur, the longer they live, and then the intrinsic biology all could predispose a tumor to be refractory to initial radiosurgery treatment. So can we use this strategy in a newly diagnosed setting as well? And really, this is a long segment into the topic of today's talk. This slide I've already covered. So how do I safely convince people, convince the IRB to allow me to do this in the upfront setting? Well, it turns out when we prior to translating the strategy from a recurrent setting to a newly diagnosed setting, we carried out a study looking at the risk of biopsy plus LITT versus LITT alone. The reason this is important is that there are patients who have diagnostic uncertainty, a brain metastasis that might be touching the dura, a patient who had multiple cancer that you don't know which cancer is contributing to the brain metastasis. So for a subset of patients, a biopsy is necessary. So for me, I was thinking to myself, well, if the safety of a biopsy plus LITT is the same as a biopsy, which is the same as LITT, then for these patients that need a biopsy, I can safely institute a biopsy plus LITT type of paradigm, and then test whether or not test the safety and the efficacy of LITT plus consolidation SRS in an upfront setting. And so this is a data set derived from, again, the NRD. This is my own data set comparing patients who I performed LITT versus biopsy plus LIT. And the fact is, the safety profile of these two procedures are identical. So with that established, I then treated, again, under RIB observation, a number of patients who had equivocal mets. So for example, this is a 62-year-old with a breast cancer with an intraventricular lesion. Did not have a prior MRI. Could this be a benign intraventricular lesion that was just previously not seen? Is this a metastasis? So I think a biopsy is warranted. Here's another gentleman, 45-year-old gentleman with a lesion that abuts the falx. Is this a dural met? Is this a odd-looking meningioma? Again, this is a patient that required biopsy. Here's a patient who had a history of breast cancer and melanoma and had this new contrast-enhancing lesion in the brain. Is this a MET from breast cancer or melanoma? That matters. In these patients, we ended up doing a biopsy, and as the biopsy is complete, we then perform a laser ablation of the lesion. And then within 30 days of treatment, we then perform stereotactic radiosurgery to the ablation cavity. And so here's the outcome. We were able to collect 10 patients within a span of approximately 4 years who required metastasis for biopsy for definitive diagnosis. And then we treated them with laser ablation, followed by stereotactic radiosurgery within 30 days. None of these patients require steroid use that's referable to the treated lesion. Sometimes the patient will have another lesion somewhere else that causes edema requiring steroid, but not to the original treated lesion. And you can see again, the progression-free survival was quite good. We're talking about almost 2 years of 100% local control. Here is an illustrative example. Here's a patient who has a lesion, again, that abuts the dura. We biopsy this and show that this is a metastasis. We treated it with LITT. This is using the Medtronic visual aid device. And then we treated this cavity with SRS. And this is approximately 2 years later. You can see that there's no evidence of recurrence. Here's a case where there is recurrence. This is the only patient who recurred. This is the patient who has breast cancer with melanoma, and we treated with LITT. And what you can see here is for this particular lesion, I was not able to push the heat to this lateral nodule, right? Again, to the point that the heat delivery is imprecise. It's really a function of the sort of whim of the local environment. So this patient unfortunately suffered, you can see that little nodule grew subsequently despite radiosurgery. So what this told me was without the LITT, the whole tumor would have grown rapidly after radiosurgery. At least we're able to achieve some local control here. And it also taught me, again, the lesson that I learned many times in my practice, which is the extent of LITT matters in the treatment of these very aggressive tumors. So where is the current state of where we are? As I mentioned to you, Peter has a study with Monteris prospectively testing the LITT plus CSRS paradigm versus repeat SRS in the setting of brain metastasis that recurred after radiosurgery. I'm in the process of negotiating with Medtronic to support a prospective study of safety and efficacy. And the goal ultimately is an RCT that would compare resection plus SRS versus LITT plus SRS. The reason I think this is very important is more and more patients are now being treated with targeted agents. More and more recognize that time that we spend waiting for recovery from surgery, it's detrimental to the patient. So if we could replace surgery with LITT and achieve the same outcome or better, that is a paradigm that's worth considering. So with that, I'm gonna stop and answer any questions about this presentation. Again, Chris, thank you so much for the opportunity to share this work.
Thanks, Clark. That was great. We'll just get you to stop sharing your screen there for a second. We'll go to the questions. And my first one for you, and this comes up with my own practice as well, where we're operating and then performing radiosurgery as a standard postoperatively, is the timing. And what was in this particular study, what was the time from biopsy LITT to SRS?
We typically do the SRS within 30 days. And that was an artifact, not just an artifact, um, that was a function of two things. At UCSD, at Minnesota, and at Brown, typically we like to treat the patients within 2 weeks after the treatment. And I lengthened it for another two weeks because I was initially worried about the potential toxicity
Yeah.
in combining LIT plus CSRS. So the roughly 30-day was a function of when SRS is available, which is a rate limiting agent, and the fact that I was initially concerned about safety. As I do more and more of this, that concern has really tapered. I mean, I just haven't seen any problems. And it kind of makes sense from a pathophysiological perspective, right? Because when the problem with radiation necrosis is thought to be that the dying cancer is releasing irritating compounds that spread to the environment. If we were to thermocoagulate and denature those proteins first, as the tumor die, they don't release those compounds, right? And
Yeah.
so while initially I was concerned about safety, this has really turned out to be a very, very safe treatment.
And one of our audience participants asked, "What's the frequency of radiation applied in the cases?" And I think they probably mean sort of the fractionation pattern. And I think this was 5 fractions, right?
It's 5 gray times 5. And as I mentioned, I really kind of copied the Stanford protocol, right? In the early days, when they're doing cyberknife and doing fractionation, they treated a number of pituitary lesions that just abuts or even pushing into the optic, and they did a 5 by 5, and I thought that was a very reasonable sort of safety profile in that context.
Moving
But again,
forward,
being
do you
concerned,
think, do you think 8 times 3, if you're going to fractionate it, might be reasonable, or 9 times 3, or something along the lines of what the
that's a
Cleveland people are
great
doing?
question. I think that should be investigated. It shouldn't be willy-nilly kind of thing. It should be,
Sure.
hey, let's do a good study to compare. My goal is to establish the indications for this. And so every time we alter a protocol, just like with any trials, we have to go back and retest. I kept the 5 by 5 only because it was how we started. But you're right. For example, the patient that recurred, in that setting, in the case with the melanoma, it was a melanoma, not breast. I've always wondered if I escalated it, could I have better controlled it? So that's an open question. I do think that it's worthwhile testing that in a carefully controlled manner.
And then we've talked briefly about this, but the trajectory, the track that's created by the LIT, presumably you're not pulling a lot of live cells out of the track, but how do you contour that or not contour that into the SRS targeting? Do you take your tract for deep-seated lesions and go up a few millimeters along the biopsy tract?
That's a really great question. And I thought about that a lot when I first started doing this. And I was tempted to contour this because back then the guidelines, you should contour the track.
Yep.
And I didn't because I compared the radiosurgery plan with and without the track. And the volume exposure is, again, I was concerned about safety. I ultimately opted not to, with the thought that I will monitor the patient carefully, and if something happens on the track, I would radiate it then, and that would be a more focused radiation rather than the entirety of it. And so that's what I ended up doing. But I thought about that really hard, and I don't know that I had a good answer. I think that if you monitor your patients carefully, and if
Mhm.
you could treat the moment you see something, that decreases the volume. And again, a lot of this has to do with the fact that safety was my initial concern because I could wreck this strategy if I have a few complications in a limited sample set. And it's with that as a guiding principle that I didn't radiate the track.
And then I think the last thing I wanted to just touch on with you was that there's a lot of data going back actually a long time in non-CNS tumors looking at hyperthermia and hyperthermic therapy, be it photo sourced or laser sourced, in combination with radiation therapy. And I wanted to get your thought in the brain if you think there is a true synergy here rather than just kind of we're preemptively blocking cytokine release and we're preemptively
Yeah,
blocking radiation approaches. Do you think there's a synergy? And if there is, do you think down the road we'll see that we could de-escalate our radiation doses in those patients?
I think we could probably de-escalate on another ground, which is we are cytoreducing, right? We do know that again, radiation kill of tumors is fractional, right? It's never 100%, and it matters when you know 0.1% of 10 to the 15 tumor bulk, it's different from 0.01% of 1,000 cells, right?
Sure.
So on that grounds, I do think that there's a possibility we could dose de-escalate. And in fact, 5 by 5 is a very gentle fractionation,
Mhm.
and we're getting amazing controls with 5 by 5. So I now with regard to hyperthermia, I think it's a black box. When I review the literature, right? Remember, these patients are treated, you know, roughly 20 days after the hyperthermia. There is no hyperthermia anymore at the
Yeah.
time of SRS. So I looked into this literature. There is a literature that suggests that the biological consequences of hyperthermia is can be synergistic with radiation in terms of tumor cytoactivities. The problem is I can't prove that to you. I can't prove to you that by the time of SRS delivery, that the biological effects of LITT is persistent or synergistic. I do think this is a fruitful area for investigation. I do think that if you have an intraoperative radiation modality like you have, you're uniquely positioned to ask that question,
Yeah.
because for the rest of us, where we don't have intraoperative radiation, right, we have to wait. And
Sure.
once we wait, we don't know what's happening. So I think this is a unique research opportunity for you and groups like you that have intraoperative radiation.
Yeah. There's always more work to be done. Well, Clark,
Yes.
that was fantastic. I thank all the participants and the attendees for today. Once again, thank the Journal of Neuro-Oncology. I think this is a great paper, and I encourage everybody to read it in its entirety. And the Seattle
Great.
Science Foundation. And with that, I will sign off until next time. Thanks, everyone.
Thanks, everyone.